Hello, my dear curious and studious students of surgery. Myself, Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome, dear students, in my surgery lecture series number 18. That is the chronic and chronic relapsing pancreatitis, complications of acute pancreatitis. In this lecture, we will learn the complications of the acute pancreatitis, massive hemorrhage, development of pseudocyst, pancreatic fistula, pancreatic necrosis, pancreatic abscesses, chronic and chronic relapsing pancreatitis. Now, first we start with the complications of the acute pancreatitis. Main complications of acute pancreatitis is massive hemorrhage, may account for fatality initially. Development of pseudocyst occurs in about 12% of cases. Formation of pseudocyst requires about 4 weeks or more. It is collection of pancreatic juice enclosed in a wall of fibrous or granulation. 10% after acute pancreatitis and 40% after acute necrotizing pancreatitis, that is the ANP, acute necrotizing pancreatitis. Pancreatic fistula, due to disruption of main pancreatic duct and its branches, successful stenting by ERCP may be detected by severe edema and stricture. Octreotide reduces incidence of magnitude of pancreatic fistula. Next complication of acute pancreatitis is the pancreatic necrosis. Indicates a focal or diffuse non-viable parenchyma which is typically associated with peripancreatic fat necrosis. Dear students, you can see on your screen there is an image of development of pseudocyst. This is the image of on the CT scan, and next is the image of pancreatic obstruction due to the stones, and next image is the pseudocyst in the pancreas. You can see the anterior wall is open of the stomach. Anterior wall of the stomach is open. Posterior wall is also open, and there is a marsupialization and suturing of pseudocyst of pancreas, sutured with the posterior wall of the stomach. Now this is the another image, cyst of the pancreas, long communicating pseudocyst of the pancreas. This is the another image of ERCP. You can clearly see there is a pancreatic fistula. Next abnormality of the pancreas, complication of the pancreatitis is the pancreatic abscess, a fatal complication. Mortality rate is 100%. Causative organism is the Clostridium. Abscess should be drained retroperitoneally. Extraintestinal bleeding 3% to 6% of the incidences. Multiple organ dysfunction syndrome, that is the MODS, MODS, due to IPN, infected pancreatic necrosis. Next complication is the gastrointestinal fistula due to autodigestive necrotic process, recurrent infection, obstruction of CBD, collection of blood in laser sac, but dreaded complication, acute renal failure, hematemesis and melena. The next image is the abscess of pancreas, images on the CT scan. Here is the pancreatic abscess. Then next complication is pancreatic ascites due to cirrhosis following alcoholism. Diabetes mellitus, as a sequel of acute pancreatitis, the frequency of diabetes mellitus increases with the number of attacks. Acute psychosis, pseudoaneurysm of major peripancreatic vessels may be associated with infection, recurrent bleeding, and may culminate fatal hemorrhage. Chronic pancreatitis due to damage to the pancreatic tissue. Quite progressive fibrosis leading to pancreatic insufficiency, which gives rise to steatorrhea, nutritional deficiency, and last diabetic mellitus. Now the management of local complications are presence of an abscess or necrosis in or around the pancreas, which is called IPN, infected pancreatic necrosis. Necrosis can manage conservatively by percutaneous drainage with rigid scope, and all the pancreatic debris is removed. A CT scan is the best investigation to know whether a necrotic fluid or an infected fluid has been formed or not. Laparotomic removal of necrotic tissue is called necrosectomy. Nutritional support, parenteral nutrition, feeding comments, nice peristalsis is resumed. Now the chronic and chronic relapsing pancreatitis. Chronic pancreatitis, no such asymptomatic period for chronic pancreatitis. Progressive destruction of gland is commonly seen in the chronic pancreatitis. Abdominal pain is continuous and unrelenting. Chronic relapsing pancreatitis, asymptomatic period of varying duration. Pathogenesis behind the chronic and chronic relapsing pancreatitis are chronic alcoholism. Alcohol causes edema and inflammation of the papilla of Vater or obstruction, biliary tract disease, cholecystitis, calculus cholecystitis, choledocholithiasis, dysfunction of fibrosis of sphincter of Oddi, benign or malignant growth of the ampoule of Vater are important etiological factors. The common channel theory, obstruction of ampoule of Vater, hyperparathyroidism and hyperlipidemia are the pathogens behind the chronic and chronic relapsing pancreatitis. Dear students, you can see the image on your screen of the chronic pancreatitis. Next pathology is intrapancreatic duct obstruction due to alcoholism. Plugs of proteins has been precipitated and often calcified in the ductal system of pancreas. Hereditary pancreatitis, malnutrition and large explained idiopathic group from the rest of the causes. Pathology, histologically, lobules of functional acinar and isolate tissues are surrounded by thick band of fibrous tissue. Alternating areas of stricture and dilatation of main ductal system. Calcification occurs in later stages, intraductal or interstitial. Calcification and ductal distortion are common features of familial or genetic chronic pancreatitis. Clinical features of chronic pancreatitis: history of chronic alcoholism and repeated attacks of pancreatitis, pain reduced to left shoulder, nausea, anorexia and weight loss, steatorrhea and malabsorption syndrome, diabetes mellitus a common accompaniment due to failure of internal secretion, mild jaundice. Now the clinical features of chronic relapsing pancreatitis are recurrent attacks of pain in the epigastrium, a main symptom. Weakness or fatigue is common and often herald oncoming attacks. Omitting jaundice. Investigations in chronic relapsing pancreatitis are decreased pancreatic secretions. Lund test. A test meal is given. Duodenal juice is collected for 2 hours. After meal by aspiration through the Ryle's tube, trypsin is decreased by 2 microequilibrium per minute per ml. Normal trypsin value is 9 microequilibrium per minute per ml. Straight X-ray often shows pancreatic calcification. Intraductal or diffusely scattered within the pancreatic parenchyma. Barium meal study will show enlargement of C loop of duodenum. USG and CT scan helpful in demonstrating pancreatic microcyte calcification or dilated pancreatic ducts. Next investigation is MRI will show outline of the gland as also the texture, evaluate both parenchyma and ductal disease. ERCP shows ductal dilatations, ductal strictures and calculi. Treatment in the acute chronic and chronic relapsing pancreatitis are medical treatment. Main aim to control the abdominal pain. Treatment of exocrine insufficiency and 30,000 unit lipase and 10,000 of international units of trypsin is to be given. Treatment of endocrine insufficiency, that is the insulin therapy, should be given. Surgical treatment, the goal of the surgical treatment in chronic and chronic relapsing pancreatitis are to relieve the pain and to present endocrine and exocrine functions. Dear students, you can watch this image on your screen, that is the surgical treatment in the chronic and chronic relapsing pancreatitis. Some surgery is given in these images. There is a end to side anesthesia of jejunum. The body of the pancreas is directly connected to the duodenum and there is a blind end of the duodenum, and the partial gastrotomy is done in the diagram B, and side to side ionostosis of stomach and the jejunum. And third diagram of surgery is there is a blind loop Rho and Y. The body of the pancreas is directly connected to the duodenum and there is a gastrojejunostomy. And the fourth of diagram showing there is a side to side ionostosis of gastrojejunum. Now the ampullary dilatations, drainage procedures of pancreatic duct, Tuhal's pancreatico-jejunostomy, a limited distal pancreatectomy, end-to-end anastomosis of Rho and Y of jejunum, cysto-longitudinal pancreato-jejunostomy, when dilated pancreatic duct and presence of calcifications side to side longitudinally and intestinal continuity is re-established by the Rho and Y jejunostomy as we see in the images. Then the third surgical treatment is the excisional procedures, modified Whipple operation, pancreatico-duodenostomy, when parenchymal disease is limited to the head of the gland, distal subtotal pancreatectomy, limited in the body and tail, total pancreatectomy, when the pain continues after laser resection, that is the IDDM, insulin dependent diabetes mellitus, pancreatic autotransplantation to preserve endocrine functions. Dear students, here is the end of our surgery lectures number 18, that is the chronic and chronic relapsing pancreatitis. Thank you.